Alaikum warahmatullahi wabarakatuh. Good afternoon, everybody. Welcome to our third webinar series on prioritized zoonosis in Somalia 2023. The objective of this webinar is to enlighten the importance and increase awareness regarding zoonotic disease among different parts of stakeholders. If you are missed the last two webinars, still you have chance to rewatch again. All of them were recorded and you can find Somalia One Health Center website. For today, we will have discussed Rift Valley fever, its epidemiology and public health importance. We will hear from Dr. Mohammed Ibrahim. In his biography, Dr. Ibrahim is an assistant professor in epidemiology. He has a PhD in epidemiology from University of Basel, Switzerland, and has reach of experience in teaching research and community engagement in the area of zoonosis, food safety, and antimicrobial resistance. His main area of research interest is vector-borne disease and zoonotic diseases, food safety, and One Health policy and practice. He has depth knowledge in One Health concept, IHR monitoring and evaluation framework tools, multi-sectoral One Health coordination mechanism, and national bridging workshop. Currently, he is a national epidemiologist and One Health focal point for the World Health Organization country office in Ethiopia. Just a little housekeeping before we get started. If you have any question during presentation, please type in the chat box. I will bring them during presentation, and we will also have time for question and answer at the end. Without further ado, I will turn the time over to you, Dr. Mohammed Ibrahim. You are welcome.
Thank you so much, Dr. Amir. Please confirm me if you can hear me before I proceed.
Yes, you can proceed. Your sound is clear.
Okay, thank you so much for having me, and Assalamu alaikum warahmatullahi wabarakatuh. And I will try to share my, excuse me. Sorry, excuse me.
Just your bureau.
Sorry, Dr. Amir, it's stuck, so just give me 1 minute.
Okay.
Okay,
Yes.
please, feel free. Please.
So hopefully you can see now my slide.
Yeah. Yes, very good. You can proceed.
Okay, thank you once again, and I am very happy to join you as Abrar and Somalia One Health Center, and this is a good opportunity to discuss the most important topic, that's the One Health. And recently we know that Somalia have prioritized about 7 zoonotic diseases. And this webinar series will help for the participants to understand each and every one of these zoonotic diseases that have been prioritized by the country. I will start with the title, which I will talk today is all about the Rift Valley fever, especially I will touch about its epidemiology and also the public health importance of this disease. As Dr. Ahmed said, I will not take more time. My name is Mohammed. I'm working with the WHO country office as a One Health technical officer, and I'm also a national bridging workshop catalyst for Ethiopia. My presentation outline will include the introduction of Rift Valley fever, the history, transmission, epidemiology, prevention, and control. So, as an introduction, as you are aware, Rift Valley fever is a viral arthropod-borne zoonotic disease caused by the genus flavivirus. And in humans, most infections are asymptomatic or mild illnesses. That's 98% of the infected people do not show the clinical sign. And sometimes in the severe cases, it causes the hemorrhage, encephalitis, visual disturbance, or blindness, and also death. For historical background for Rift Valley fever, the Rift Valley fever virus was first identified in 1931, during which an investigation was being conducted in a sheep farm where there is an epidemic in the Rift Valley fever of Kenya. That's where the name Rift Valley comes from. It's at the part of that Rift Valley in Kenya. And next to that epidemic, the explosive outbreak was reported from Egypt in 1977. And this was introduced through infected livestock trade. And we'll talk about later how the livestock trade or export of live animals from Horn of Africa to other countries, especially in the Middle East, will have a consequence on this disease and like such kind of a disease. So then that means we are not talking about the public health importance, but also the economical impact of the disease. And then the major outbreak reported or documented so far was happened in 1997 to 98, and that occurred in 3 countries in Kenya, Somalia, and Tanzania. And this outbreak was due to the El Nino event, followed by extensive flooding. And lastly, till 2000, all the outbreaks were in Africa continent. But in 2000, it was emerged out of the continent, that's in Saudi Arabia and Yemen. And this again, the same with that of Egypt. It was due to the infected livestock trade from the Horn of Africa, because Horn of Africa are mainly pastoralists and their livelihood depends on livelihood in the livestock and the livestock products. And one of the major income for this pastoralist community is exporting the live animal to Gulf countries. So in 2000, the outbreak was due to that imported live animals from Horn of Africa. Just to take a little bit in depth of the epidemic so far from 1932 to 2011, as you can see in 1977, it was occurred in Egypt, and the estimated cases was 200,000, but the reported cases was only 18,000. This shows that how underreported cases are always occurring at a global level. At these areas that where the Rift Valley fever outbreak is endemic. And the death was about almost 600. And then it flowed by the one that I have mentioned in 1997 to 98. This was the the highest or the major outbreaks so far that have been documented that occurred in Kenya, Somalia, and Tanzania, where the estimated cases are about 90,000. But the dates in this table, 458, is only from Kenya. And next to that is 2006 to 2007, the same, these three countries have reported the Rift Valley fever. And if you look at the right graph, the red color is for the East Africa. And from 1940, if you see, until 2011, the red are there, except some few countries which are out of the Horn of Africa or East Africa, like Egypt and Mauritania, and the rest you can see it's only in the East Africa. In terms of epidemiologically, the Rift Valley fever epidemics, especially in East Africa, it occurs often when there is a heavy rainfall followed by flooding. This means that it favors the massive hatching of mosquito eggs, whereof a part is already trans-ovarially infected, and this will lead to rapid spread of the virus to animals, and to some extent to humans also. And the ability of the Rift Valley fever to spread outside the traditional endemic countries, like we have seen in Saudi Arabia and also in Yemen, depends on the large range of arthropod vectors that can transmit the virus. So as long as you have a large range of arthropod vectors and hosts, the transmission of the viruses or the occurrence of this virus outside of the endemic areas cannot be ruled out. But it's yet unknown if the virus needs to be reintroduced before outbreaks, or if the undetected virus circulation in the vertebrate or mosquito that is in the vector is sufficient to maintain the virus. So we don't know more about this, whether the virus should be reintroduced before outbreak occurs, or if this virus circulation have the sufficient to maintain the virus until the other epidemic occurs. For the distribution of this Rift Valley fever disease, at the global level, if you can see, all the red color are the endemic or previously known serious outbreaks, including Somalia, Ethiopia. No, Ethiopia is not included. It's Somalia, Kenya, Tanzania, the three major countries that we have mentioned that occurred in 2006 as well as in 1997-98 is the red one. And the most part of the continent is red, which means it's endemic or previously known serious outbreaks have been reported. But the yellow one, there are reports predict occurrence, or sometimes it's a serological evidence, like Ethiopia. We don't have any outbreak so far in Ethiopia, but serological evidence shows that there is an infection, and we will talk about that one later by some of the studies that have been conducted. On the left, it's the same with this graph. So the green, the yellow ones, the blue ones are those that the country is reporting endemic diseases or substantial outbreak of the Rift Valley fever diseases have been occurred. But the green one are those reporting very few cases, which are predict isolation of virus or serological evidence can be seen. In transmission, we have said that it's a vector-borne disease, and vector, what we mean majorly here is the mosquitoes. That means the infected Aedes species feed preferentially on domestic ruminants, and we know that domestic ruminants are amplifiers for the disease. and which act on that, and then it can transmit to other animals as well as to humans. But there are also broad vector range of mosquitoes, not only Aedes, but also Anopheles, Culex, Mansonia, etc. There are also other blood-suckling insects such as ticks and midges. So if you look at the graph at the left, sometimes there will be a normal range where you have a few floodwater mosquitoes. That means there will be a low epizootic potential. That's where the inter-epizootic cycles occur. But due to the high rainfall flowed by flooding will increase the favorability of hatching the infected eggs to larvae, and that larvae will infect animals before going to humans. Because we have said that the domestic ruminants are the amplification of this virus, and then it will transmit to humans. And this graph shows that where to put the control or any intervention you want. We have a climate data, and this climate data will help you to prepare ahead of before the outbreak in animals and then to humans. Whenever there is an amplification of the virus, it will increase the outbreak possibility until you have also not only animal outbreak, but also human outbreaks. And the last picture shows that the Aedes species, which lays the infected eggs that are dormant in soil, and that they transmit to animals, but mainly the secondary vectors such as Culex will transmit from animal to humans or from the infected animals to non-infected animals. So in a short, the transmission in livestock is by infected mosquito bites, and it depends on the species of mosquito and other biting insects, and mainly affects the sheep, cattle, camel, goats. In transmission in humans, mainly it's a direct contact with the blood, meat, milk, and other fluids of infected animals. A bite of infected mosquito can also transmit the disease, but it's not that much, it doesn't play a huge role for the transmission when it comes to humans. And there is a question also for aerosol transmission, which generated during its slaughtering of infected stock, and much research needs to be done to understand more if this holds. I wanted to share with you these predictable models that have been conducted in 2006. And this is a Rift Valley fever calculated risk map for the Horn of Africa. As you can see, the red color is the persistent rainfall as well as the vegetation growth. Whenever you have a rainfall and high vegetation growth, that is the potentiality of the risk will increase. Whereas the human cases, the blue, we will come to these cases, but first of all, the green ones of this map shows that the potential epizootic areas, whereas the red are the Rift Valley fever risk areas. And if you can see the three countries, Ethiopia, Somalia, and Kenya, that red in the circle is where you have a high risk for Rift Valley fever outbreaks. We know from Somalia and Kenya, but we don't have any outbreak yet in Ethiopia. That doesn't mean we will not have any outbreak. So there should be some cautionary measures to flow and monitor, because the community in this border are pastoralists. That means a free livestock movement in and out of the border are frequently, and it's normal. This graph, you can see the blue dots, that's the cases, both the blue as well as the yellow, where the blue ones where you find is in the red color. That means the high risk areas. And this red are inside the persistent rainfall and vegetation growth areas, whereas the yellow ones, the cases are within the potential episodic areas. And the last at the left is a new study that have been conducted in Ethiopia, where the authors predicted the potential distribution of the vector mosquito in Ethiopia. And look at the Ethiopia map. You can see the red color are in the east and the southern part of the country, where you have a variety of vectors that can have a potential for transmission of the disease. And it's mainly in Somali region in Ethiopia, and also part of the southern nation and nationalities people, which is in the southern part of the country. Therefore, transmission of the virus utilizes One Health approach, means the health and the condition of the environment, animals and humans intersect and influence each other. So One Health approach is a critical for this if we wanted to study the Rift Valley fever. And the Rift Valley fever is a very good case study if we wanted to test the One Health approach or the cost effectiveness of One Health approach. I wanted to share with you only 2 studies that have conducted in Ethiopia and Somalia. And I'm glad that one of the study recently that have been conducted in Somalia, the author is Dr. Mohammed, who is the rector of Abrar University, who is hosting this webinar series, and where he was looking at with his colleagues, and also the moderator here, we do have Dr. Amir, who is also co-author for this paper, where they look at not only Rift Valley fever, but also Brucella species in ruminants in Somalia. At the left, it was a study, part of my PhD, where we did a seroprevalence of not Rift Valley fever, but also brucellosis as well as Q fever in both in human and livestock in Somali region. For Ethiopia, the apparent seroprevalence of the Rift Valley fever was 13% in humans, almost 18% in cattle, 43% in camel, 6.3% in goats, and 7.4% in sheep. You can see the highest seroprevalence were recorded in cattle as well as camel. Similarly, even though the seroprevalence is very low in Somalia, where they have found only 2 cases out of 609, which accounts about 0.3% in cattle, that will match the second stage flow. That means next to camel. Our study found that 18% was in cattle, and similarly in Somalia. But keep in mind that the first case confirmed in Somalia was in 20th of January 2007, where it has been reported 107 cases and 54 deaths. That means about almost a 51% mortality rate. When we come to prevention and control, for prevention, what we are emphasizing is the control of the mosquito egg laying sites, eggs, and the larvae, as well as the adult mosquitoes. And also to eliminate the breeding places and target mosquito larvae. This is the major measures that we should have to consider when we are talking about the prevention measures for Rift Valley fever. For control, mosquitoes, we wanted to focus the elimination of the mosquito egg laying sites. Vaccination is so important. You are familiar with that. We don't have a human vaccine so far for Rift Valley fever, but there are, sometimes we use it for livestock, because they are the source, and because of the livestock, the domestic ruminants, that will act as amplifier, and the vector will transmit from animals to humans. The vaccination of livestock should be considered, but still we are not using those vaccines in everywhere. Especially we're only using for high risk areas where we have outbreaks. And also restrict movement of animals, avoid mosquitoes, and use repellent. And whenever you have some information for such kind of outbreak, you recommend not to slaughter any sick animals, and use personal protective equipment, and avoid contact with infected animals and the blood tissues as well as blood. These are not the only ones, but also there are many other additional measures we can take into consideration. One is the monitoring of intra and inter-country migrations, using robust quarantine system, especially when it comes to imported animals. Because we have seen in Egypt as well as in Saudi Arabia and Yemen, it was through infected imported animals from Horn of Africa. And of course, as most of the adult animals do not show severe clinical manifestation during the virus infection, active surveillance of livestock herds in endemic countries is recommendable. And lastly, but not the least, suitable vaccine program are very useful, especially to help to prevent uncontrolled spread of the virus. So what are the major interventions so far that have been conducted in East Africa when it comes to this disease? One is the social mobilization, slaughtering ban, especially when there is major religious holidays like Eid festivals, because this is the time when the livestock from Horn of Africa are sent to Middle East because of the Eid festival. And the livestock quarantine, and as well as vaccination, is also the major interventions in East Africa that have been conducted. But vector control, which is a very critical, are very minimal. So we should have to think of that also, how we can increase the vector control. There are also some challenges in regarding on this intervention. One is the poor accessibility because of flooding, and timing occur in peak holiday season. In this area, there is a limited health services in the region, and coordinating surveillance between livestock and human, that's through One Health approach, is also a major challenge. So what is our key message on this presentation? I will conclude in my presentation with this key message that One Health approaches are critical to detect most important sources for people, and provide also evidence of needed future negotiation on potential actions in surveillance and interventions. So not only for Rift Valley fever, but now we are talking about Rift Valley fever, and also we are talking about One Health approach. So this is a critical, and we should have to always think of in that way. We are talking about One Health approach. That's why we are prioritizing zoonotic diseases. And these diseases cannot be controlled or prevented by a single sector. And all the relevant sectors should come together for a better prevention and control mechanisms. Thank you so much. This is all about my presentation. And if you have any question, I will be happy to respond. Back to you, Dr. Amir.
Thank you, Dr. Ibrahim, for a nice presentation. It was very interesting, and I hope all our participants are enjoying and they will have questions to ask. Please feel free, if you have a question, you can write on the chat box. Otherwise, you can raise your hand and we'll give you talk. If I start myself, Okay. When regarding one of your slides, you are discussing with the prevalence of Rift Valley from Somali region in Ethiopia. The prevalence was very, very high compared to Somalia. Can you say something about that study?
Okay, if you don't mind, should we first receive all the questions at once so that I will respond at once? Or I should have to answer for each questions? What's the approach?
Yeah, I think it's better to answer.
Oh, okay.
Thank you.
So thank you for your question. Yes, the seroprevalence of the Rift Valley fever in Somali region is higher when you compare to, for example, the study that you also were a co-author. There are many reasons for that because, you know, in Somali region, we do have the largest pastoral community in the country, and it's a vast region where the region has a border with Kenya, Somalia, and Djibouti. So that means if you see the peripheral areas, these pastoral communities are living in the peripheral areas where you have a free livestock movement. And that means still we don't have the disease. We cannot confirm that, and we don't have any outbreak. But if you look at the infection, the prevalence, seroprevalence, it was high in camel as well as cattle when you compare to the rest, the sheep and goats. That means most of the time the camel population has a free movement compared to the others. And also for cattle who are susceptible for the drought. Whenever there is a drought, the major ones that are moving to grazing and the water availability areas is the cattle. So mainly I will say that because of the location and because of the nature of the population, which are pastoralists, have a broad neighboring countries. Well, now, when we are talking about the neighboring countries, we are talking about the two countries which have reported outbreaks of Rift Valley fever, both in 1997, 2006, and all those. The highest was, the major ones was in 1997, 98. So that means there will be a chance to introduce this infection while the migration of livestock movement at the cross border is occurring. If that answers your question.
Thank you, Doctor. Yeah, it was very good way. And I understand clearly this, this we can see how important to control our border. Since the disease is not present in Somali region, but livestock are import from neighboring countries. So the antibody is there. Yeah, but the disease still is absent. Very nice. Anyone has question, please raise your hand, or you can type on the chat box.
I think the majority of the audience are Somali speaking. So if anyone wanted to ask in Somali, please feel free to ask.
Good. If I say in Somalia, qofka hadduu jeclaysanayo inuu Soomaali su'aal ku weydiiyo u furan tahay oo weydiin kara doctorka af Soomaali waa loo jaabi karaa. Su'aal chat box waxay leedahay doctor. Can Rift Valley fever be eliminated in the wolf like Renderbest?
Thank you for your nice question, Zakaria. We would love to eliminate all the hectic diseases if we can. But in my presentation, I have mentioned that as long as you have large vectors, as well as hosts which can facilitate, or the susceptible animals, which can facilitate the transmission to continue, it's very hard to talk about elimination. But first, we are emphasizing or focusing on the control programs. If we succeed with that by using a different mechanisms, including the vaccination. Now we were talking about whenever you have the infection in one, either in animals or in humans, still we have a problem for elimination measures. So at the moment, so far, it's quite difficult because every time we are getting a report that some of the vectors and new vectors can also has the probability to transmit the infection. So that means it's very hard to eliminate.
Thank you, Dr. Mohammed.
Sorry.
Ismail Mohammed, you can ask.
Sorry, Dr. Amir, I think there is another question in the chat box.
Okay.
Grad,
Please.
saying that your research in Ethiopia has been done on this Borana area, if any, what do the research? Sorry, and Grad, no, the research area was not in Borana, it was in Somali region. Our study was not included in Borana. Of course, the Borana area is also one of the pastoralist communities in Ethiopia, but it was only limited to Somali region. Thank you. Go ahead, Ismail.
Thank you. Ismail, please proceed. You can ask your question.
Yeah, Mr. Ram. My question is, who is susceptible for this disease in livestock? Who is susceptible to disease in livestock?
I think if I can understand well, which animal is more susceptible when it comes to livestock?
Yeah, thank you. Yes, mainly, in general, it's the domestic ruminants, but mainly what we are talking about here is mainly sheep and cattle are more susceptible compared to the other species.
Very good. Thank you. Anyone else?
معناها لكن كما دقنو فضلا تانا معناها كما دقنو هو كالودن susceptible معها لكن مركز اكتيت دراسات إلا حد اللي سميه أدل آديات وحي وبدنيهين و that's why وحانو target قرينا إنه sheep and cattle مركز البربر ديو كوكا. Thank you.
Bruce, please.
So I wanted to ask a question, which is about, as Rift Valley fever has a vaccination for the animals, does it have a vaccination for the human being as it's a transmission disease? Thank you so much. That's my question.
Thank you, Hiba, for your nice question. No, as I have mentioned in my presentation, we don't have so far a human vaccination. We don't have a human vaccine for Rift Valley fever, but we do have livestock vaccine. Still, it's not commercialized, and as I have said, we are only using those epidemic areas where we do have frequently Rift Valley fever outbreaks.
Okay, thank you so much for your answer.
Very welcome.
Thank you. Anyone else? Feel free to ask. It's your turn to understand about all things related to Rift Valley.
And just to add one thing that I haven't mentioned in my presentation, the ongoing transmission or inter-epidemic transmission of the disease. Studies that shows both I have seen from that the paper that I have presented from Somalia, as well as our study, shows that the age of the animals were as young as 1 or 2 years old, which means, and you know, the interepidemic most of the time is every 5 to 7 years. The interval is in between that. Sometimes you can see within 4 years interval, but most of the time it's in between 5 years to 7 years. That means if you find animals with the age of 1 or 2 years with infection, that means there is ongoing transmission. And that's why we are not ruling out anytime there may be an outbreak. That's why we should have to have always caution for monitoring and doing active surveillance, especially in those areas.
Good. Thank you. Dr. Ahmed, please go ahead. Your question.
Thank you very much. I hope you are hearing me very well.
Yes.
I just want to thank first Mohammed for this wonderful presentation and informative, and it could help also for the recently prioritized zoonotic disease for Somalia. And the second, I have a question for Dr. Mohammed. As I have seen that your presentation including infection is zero prevalence in humans. So it could be mixed up with other febrile patients, because as we know, many physicians, they do not treat them these Rift Valley fever and other more zoonotic diseases. So could be missing up in the physician side.
Sorry, it was interrupting the sound. If I understood correct, thank you so much for the nice question, and I'm very glad to see you again, Dr. Ahmed. If I understand correctly, that first our if you are talking about our study, it was on. It was a community based, it was not in health facility based. And I think if your question is about the febrile illnesses, out of that febrile illnesses, how much can be other viruses or any other diseases which are related to Rift Valley fever? If that's the question, of course, it can be, but in this study, what we were, it depends on what kind of kits you are using, because for Rift Valley fever, we were using only for a special kit that is the competitive ELISA, and that means we cannot look at other viral diseases which are related with the Rift Valley fever. For example, if you take an example of MERS, and yes, if that's the question, no, we haven't seen, but absolutely it can be other reasons why there may be other infections rather than Rift Valley fever, but our focus was only on Rift Valley fever. Is that your question, Dr. Ahmed? If I get you correctly, otherwise, please.
I think it's good you are hearing me now very well.
Yes.
Okay, I'm just talking in general perspective of the disease and not from the study that you have done in Ethiopia. We know that nowadays awareness is very important all of us in vet, in medicine, in the environment, and other things. So Rift Valley fever has already confirmed to be serologically affected present in humans. So our physicians in general, they are not taught in medical schools about Rift Valley fever. Only the vet schools are taught. So such presentations are very important to other physicians and public health professionals to have understand that the Rift Valley fever could be present in their patients, so they can be mixed up or misdiagnosed with other febrile patients. So that's what I was talking about. Thank you very much.
Thank you, Dr. Ahmed. You raised a very critical concern, and that's why I concluded with my presentation the key message that One Healthy approach is the only solution, not only for Rift Valley fever, but throughout all other zoonotic diseases where we should have to look at a human-animal environmental interface. And regarding the febrile illnesses, of course, everywhere at the global, not only in Africa, but also at the global level, the problem is maybe they have the medical students, they may learn from their undergrad about a little bit about in microbiology for Rift Valley fever or any other subject, but they will not continue with after the graduation. And always we should have to make advocacy, and we are trailing and advocating that we cannot work in a silo. Unless we come together, history tells us that no single sector can solve all those complex public health emergencies. And recently we have seen that a good lesson from COVID-19. And who knows, the next outbreak can be most probably can be a zoonotic in origin. And that's why we are always advocating for One Health approach. If we wanted to have, and for report, you have seen that there almost more than 75% of these emerging and emerging infectious diseases are zoonotic, which means, is it better to prevent or to go after all those problems come into home? That doesn't make any sense. We should have to work together in a holistic approach, in multi-sectoral, multidisciplinary approach, if you wanted to tackle such kind of complex threats. Thank you, Dr. Ahmed.
Thank you, Dr. Ibrahim, the way you address, and thank you also, Dr. Ahmed, the point that you are raised. Now, Abdurrahman Barre, please feel free to ask. You can unmute yourself.
Okay. Hey, everyone. I'm Abdurrahman Barre. I'm a veterinary pathologist from University of Nairobi, Kenya, and I'm happy to participate this session today. I'm asking small questions. As we know, this Rift Valley fever is a respiratory disease, and we know we are relating for Ethiopia, Kenya, some Rwandas, Ugandas. How can we control that disease as a transborder for Somalia, Kenya, and Ethiopia? You know, people are suffering, are going to the other countries and coming back to the countries. Even farmers, they are going to Kenya, Ethiopia, Rwanda, Tanzania. So how can we control for that Rift Valley fever in our society or in our farmers?
Thank you, Abdurrahman. Again, a very interesting question. I'm hearing echo. Okay, now it's good. Yes, if you were present during my presentation, that's why we are focusing on not only the cross-border. If you look at the Mandela Triangle, all those communities in Kenya, in Somalia, and Ethiopia are the same community. pastoralist community and the Somali community who are living in that periphery have livestock movement. And now we have a cholera being together to discuss and to come up with a solution for that. So in a nutshell, if I try to respond to your question, the only way to solve is to come together. That's why now we are planning also a simulation exercise at the cross-border tabletop exercise, and also a hybrid type of that will be a functional exercise between Ethiopia, Somalia, and Kenya, and where we are inviting One Health stakeholders and also all related and relevant partners, development and non-developmental partners. What we are going to do is, at the end of the day, is to have a mechanism of platform where we can share information, data, and we can exchange all those expertise so that we tackle a common threat. For example, in this case, the Rift Valley fever. And I have mentioned in my presentation that the Rift Valley fever outbreak reported from the two countries in Somalia and Kenya are bordering with Ethiopia, where we don't have any outbreak so far. That doesn't mean we should have to sleep and don't worry about the outbreak of Rift Valley fever. We should have to work together, exchange information, data, and early warning system should be in a place so that we can predict the occurrence of such kind of outbreak, so that a huge impact, not only the public health perspective, but also we are talking about here pastoral community, where there will have a huge economic impact if outbreak occur. That answers your question, Ibrahim. Thank you.
Thank you very much. Thank you very much.
Thank you. The next, Mohammed Abdi Hussein, please ask a question.
Sorry, Mr. Amr, it's a technical error. Sorry.
Okay. Anyone else?
Abdurrahman, is that the old hand or a new hand?
I don't know. It was my hand, but now I don't know.
Yeah, but you can unraise your hand again. Yeah, it's still just raising.
Okay.
Zakaria Issa,
Okay.
please go ahead for question.
Yeah, I have a question. Is it known the actual reservoir host of this disease? That's my question. Can you hear me?
Yeah, please, can you repeat your question?
Is it known the actual reservoir and host of this disease? Who is the actual reservoir?
Did you get Dr. Mohammed?
Are you talking about the resource, the reservoir for Rift Valley fever?
Yes.
I'm talking reservoir.
Yeah, actually, yeah, it's vector-borne diseases. And the thing that we should have to look at is that it's not all mosquitoes. The Aedes species, especially Aedes macentosi, have a play role in laying eggs which are infected and will be dormant in the soil for a long period of time. And then whenever there is a heavy rainfall, followed by flooding, that will favor the hatching of that infected eggs, and that larvae will infect other animals. But in that case, the role of Aedes species will be less because they are not secondary vectors compared to Culex and the other species where they will transmit the already infected animal from infected animal to uninfected animal, but also to some extent to human as well. So it's known, it comes from infected domestic ruminants and the transmission through the vector to other animals as well as to humans. That's the transmission mechanism. So it's obvious, it's very well known and highly studied on that way. And it's not kind of a disease that where we look at or questioning where is the reservoir, where can be the source of that infection or outbreak. It's known. The question is how we control it.
Very good. Nagat Hussein, please, you can ask your question.
Yeah, thank you so much for inviting us to this interesting presentation. Can you hear me?
Yes.
Yeah, my question is, Professor, could you tell us if the prevalence of ectocephaly has been increasing or decreasing since 2012 in Somali countries? And are there factors that prevent this disease to be decreasing or eliminated?
Your sound is too loud. Can you say again more loudly, please?
If the prevalence, could you tell us if the prevalence of Rift Valley fever has been increasing or decreasing since 2011 in Somali countries? And are there factors that prevent this disease to be eliminated or decreasing?
Thank you so much, Nagat. This is a very good question. For the first part of the question, I will leave to Dr. Amr and Dr. Ahmed because they should have to answer. But so far, the studies of the prevalence, especially for Rift Valley fever, whether it's increased or decreased, I will leave for Dr. Amr and Dr. Ahmed. But the factors that can increase the susceptibility of that, even I think the study of Dr. Amir, and Dr. Ahmed, was in Afgoye, and it was in Johar. That means they selected, I think, because wherever you have a high vegetation growth and high rainfall compared to the other areas, that's where you have the probability, the potential risk of this disease. And there are many different models that predicted by looking at the NDVI as well as by looking at the vegetation growth in those areas, because that is related to the vector population. Wherever you have such kind of favorable conditions, the mosquito population will increase. That means the transmission will increase. So regarding the prevalence, whether it increased or decreased in Somalia, I will leave for Dr. Amr and Dr. Ahmed.
Thank you, Dr. Ahmed. And I also invite Dr. Ahmed to say something about that. Please, Dr. Ahmed, I hope you hear the question.
I hope you are hearing me. Okay.
Yeah, but it's more slowly. If you can make more loudly.
Okay, thank you. I think always when we are talking about Rift Valley fever, and which is linked to the vector population and even the reservoir of the disease itself. So it could be when increase when the outbreak there, and decrease when the vectors are not there and even the reservoir are not present. In the previous point is that Dr. Mohammed raised in his presentation, it was the outbreak cases, not the surveillance of the disease. But what we have done later on, it is the surveillance of the disease in the areas that were previously present in the outbreak. And this we found with very low prevalence, 0.3% out of 609 cases. And the other thing, if you have read the paper that we have published, another professor or another scientist have done an imported animals from Somalia to Saudi Arabia, and he found a lot of positivities. But I already argued in my discussion that these animals were not brought down or found or comes from Somalia, and which regions are there, and it was in during the end of the outbreak that was raised and alarming that days. So in summary, we did a surveillance, and the surveillance was very low and not yet confirmed to be another outbreak happening in these years. But from the government side, they should have to be prepared. And we already prioritized the Rift Valley fever as one of the diseases that to be ready for it, because it affects all animals and humans. And more than that, it bans the threat that most of us are dependent on it. Thank you very much.
Thank you, Dr. Ahmed. I hope the question is answered. Nayat Hussein.
Yeah, thank you so much.
Thank you. I think there is another question in the chat box from Mohammed Sman that he said, may you indicate who is vulnerable, the vulnerable people and area for the Rift Valley fever.
That means for humans.
Yes. Yeah, it seems.
Who are susceptible. Okay. Yeah, one of the risk factors for in terms of the humans, if you look at the other studies, also similar with our studies, that comparing to animal and humans is different. For example, if you take a sex, if you take an example in animals, the female animals are highly susceptible compared to the male. And there are many reasons for that. And for humans, it's the opposite. Males are more susceptible compared to the females. So more of it, the reason can be huge, but one is that in pastoral communities, most of the time people, the livestock species, those need to take far away from the residence. For example, camel are taken by men, not females. And that can take to the forest area where you have a high population, vector populations, and that will increase the susceptibility of mosquito bite. And that's one. The other thing is all the livestock trade. If you look at, even we were talking about the livestock in the Horn of Africa are exported to Middle East. The traders, the livestock traders, that themselves are more dominant by males. The same is true in the slaughterhouse. So I'm now only talking about the sex. So if you go to age, similarly, as age increases, the susceptibility will increase. The third thing is that all those who are in direct or indirect contact with animals, if they are pastoralists, if they are butchers, if they are working in abattoir or slaughterhouses, that will increase the risk or the susceptibility of having such kind of infection.
Thank you, Mr. Mohammed. I think you are getting conclude. If I can call Ibrahim Abdullahi, please. You can ask your question.
Hello, assalamu alaikum. Can you hear me?
Alaikum salam. Yes.
All of them, good afternoon. My name is Ibrahim Abdullahi. I'm a student at Igat Sheikh Technical Veterinary School. I have a question for you, Doctor. As we all know, the Rift Valley River is zoonotic diseases and transboundary disease also. So, may also occur in Somalia mainly during the rain season, correct? So, this disease infected the animals or through the bites from the mosquito. The animals, they don't use the marcanao or marcanao. How they control? That's the question for me.
Thank you, Ibrahim, for your question. Yeah, regarding the using of insecticide nets, as I have said, the role of transmitting the vector directly to human are a little bit lower compared to transmission from animals to humans. But that doesn't mean they are not transmitting. Of course they are. So if they are not using such kind of insecticide mosquito nets, or I mean insecticide nets, that we should have to encourage people. That's why even in the control we included the repellent, using avoiding mosquito contacts, and all those risks should have to be mitigated. Of course, if they are not using, we should have to advocate for that, especially the area where we know that the outbreak is common. That's just to make a community awareness, education, and all the making risk communication and community engagement. That's the role of all of us if we wanted to reduce.
Thank you. In the chat box, Asma Hirsi just mentioned it, a very good point and very important question. She said that she arrived late. Yeah, no, don't worry, you can rewatch the presentation after this meeting. We will post our website. So the question she asked is, last year, as she said, there was outbreak, unidentified disease that resembled Rift Valley in Somaliland. In southern Somalia, she said she also heard about some tales that there are confirmed cases from livestock. So the question she asked is whether any confirmed case from Rift Valley fever in Somalia. I hope Dr. Ahmed is the one who can answer this question. Please, Dr. Ahmed Kalle, you are welcome.
Thank you very much. I think when it comes for the Rift Valley fever, the WHO in 2021 alarmed and alerted that there is an outbreak in Kenya side, neighboring Somalia. And then at Sabra University, Somaliland Health Center, we have sent a campaign to the borders of Somalia, and then we took some samples And we found a positive serological, but not confirmed it molecularly. But it's not that much as that we can declare it as an outbreak that happened. But as you said, it resembled on Rift Valley fever in Somaliland and in other parts of southern Somalia. I think it was another diseases, but not that of Rift Valley fever. Thank you.
Thank you, Dr. Ahmed. Dr. Mohammed, can you say something? Do you want to say something about this?
No, rightly said by Dr. Ahmed. And if I complement with some, I have mentioned that there is inter-epidemic or outbreaks. That means, but normally, if your question is only outbreaks, no, as far as I know, there is no any outbreak that after 2007 that I know so far. But in 2018, 2019, there was some sporadic cases in Kenya, as Dr. Ahmed said. And in that case, as long as we don't have an outbreak reported, confirmed, we cannot say, but always, all the time, we can have serological positive samples wherever you go, especially in those areas.
Very good. I hope we don't have any more questions. Sundus Isa? Is it right? You raise your hand?
Yeah, thank you so much. Assalamu alaikum. I'm Sundus Isa. I was wondering that now we are in the rainy seasons here in Somalia. And as we know, the disease usually the outbreaks occurs on these seasons. So I was wondering that do we have a data on the impact of this disease on human being since it's a zoonotic one? Do you understand?
Yes, very clear. Again, back to Dr. Amr and Dr. Ahmed.
Hello, Dr. Ahmed. You want to say something?
I think Sundus come to the point that I was raising before, that the physicians are misdiagnosing sick diseases on febrile patients. We did not done any serological or blood tests with Rift Valley fever in human site. I hope the physicians and other public health professionals and even the One Health expertise next time to do such surveillances on both human and animals. We have tried the last one that we have done in Doble in the lower Juba, the Kenyan border, to have both animal and human samples. But the pastoral is not allowed to have provide the samples to us. They only provided the animals. So this also for the public health sector, they need to raise awareness about such things to have data on both animals and humans. Thank you very much.
Thank you, Dr. Ahmed. I hope you get your answer, Sundus Isa.
Yes, very good question about Sundus, but just to highlight a very critical, very important regarding to this question. You don't worry the impact, especially because the mortality rate is very low in terms of in humans, because approximately 1 to 2% of the cases experiencing, especially for hemorrhagic fever. If you look at those with the clinical signs, especially for hemorrhagic symptoms, it accounts about 1 to 2% of the total cases. Of course, if you have such kind of, even if it's 1%, it's a huge impact because 50% of them will be a vital. So this study shows that The cases within the hemorrhagic cases are very low. That means below 2% most of the time. Even if they are below 2%, if the cases are there, the probability to have a death will be 50 and 50% more. So that's just what I wanted to complement about the impact of this disease to human population.
Very good. Thank you, Dr. Mohammed. Anyone else?
Yes. Can I say?
Yes, please.
Yeah. Amir, I'm Ismail Ali Awala. I know you know me. So I'm also a student for Mohammed Ibrahim on the Masters of One Health Tropical Infectious Diseases. So I have a question. So for the last years, I have been working with the livestock quarantines, particularly in Berbera, particularly in the detection of Rift Valley fever, particularly those livestock that we sent to Saudi Arabia. So many times we have detected cases of Rift Valley fever, especially in small ruminants and also the camel. But normally when we look at those animals that are positive for the disease, they have no clinical signs of the disease, even though the detection is based on antibody. I don't know if those animals are recovered from the disease, but my question is the most common form of this disease in livestock is subclinical, or because we can't say it's only for immunity or the antibody was circulating in the blood animal recovered from the disease, but if the most commonly born is subclinical, I'm very eager to find that one. I have also another question, even though so many colleagues have asked you previously. Somalia is one of the victims of this disease regarding to what has happened in 1998, the very long ban due to the detection of Rift Valley fever in our livestock in Saudi Arabia. So is there any policy or plan that was developed by other countries that there is a possibility to eradicate such kind of this disease in Rift Valley?
Can I go?
Yes,
Amr?
please.
Yeah, okay.
Yes,
thank you, Mohammed. Thank you so much, and nice to meet you again. You raise it too critical and very pertinent to this topic. One is regarding the clinical, subclinical. No, most of the time cases are not subclinical. Most of the time, if you have, it shows that whenever you have a huge apportion, especially for small ruminants, that's one early warning or a kind of indication that it can be a Rift Valley fever. So most of the cases are not. To the opposite, almost 98% in humans are subclinical, 98%. But in animals, no, we don't worry that. And the second question, I will talk about the policy in general. Very good. I've mentioned that these people in the Somali communities are, we say all the time, 85% are pastoralists. And their livelihood, the main income source of their livelihood is also exporting live animals to Arab countries. And the general policy in general that we should have to now, starting from now, to discuss every researcher to look at is that the relation between when we are exporting live animals to Arab countries, it's a bilateral agreement, which means if you are not a WTO, that's the World Trade Organization, if you are not a member of that WTO, any country that importing your livestock can say anything about that, whether they can say the source was from that animal, and you can do nothing as long as it's bilateral agreement. But in general, the overall policy should be that there should be some mechanisms where we can change the scenario. And in that, until that, we should have to have a strict quarantine system and screening all the animals that are exporting from that country, and asking, and we have to have a kind of a responsibility that we can ask them, the importers, we can ask them that if they can share all the informations, because serologically, when serologically tests are conducted, it's a different from when you are doing a molecular level. We are talking about exposure. If we are talking about exposure, is it still ongoing? Is it a current one or it's a past one? And all those questions summarizes the policy implications for livestock export. And in the future, we as a researcher, we should have to look at in the detail what are the gaps and what, because you have rightly said that in 1997-98, because of the ban until 2000, then 2000, it has been lifted. Immediately, the Saudi Arabia again imposed the ban. And if you look at more than 300 to 700 million US dollar have been lost because of that ban. Therefore, there are many questions related to policy issues. So as a researcher, we should have to come up with evidence-based, that we can lobby and convince the decision makers to go from bilateral agreement to that level.
Thank you, Dr. Mohammed. And thank you, Ismail, for your question. Mohammed Omar, you want to ask?
وضعت هاي صار سؤال قبل حوالي كسب عشان الفيديو هذا كتارك لكن حوالي كدوان على إن حاجة في سوالي وقعد لك رسول أوكي
سفيان
أوكي أوكي مركا إن طبعا إن مركا كهذا إنه كنترول كام استراتيجي كنترول سلوا سمي طبعا إن فاكتور كان أو مسؤولية تضع ما دام ويهاري أنا أدو بلارين هي نوتقان ارتفاعي فيفركا سبيسكا وكل عاي طبعا هيومن كي طبعا كنترول كي على الشيء طبعا نت استعماله إن الاستعمال مركان عادة لكن مركي لو يمادو دنيا طبعا هرمرتي وأي واحد يستان وحبي طبعا اسكا كنترول ويا استراتيجي كنترول كي وليه لكن أنا اسكا سوماليان ودمدان أفريكان كا هذا طبعا هرمريا مجرد مركب وحيابه أو طبعاً قاعد كسميس أما لوجو كام ترابينها تفكر كين ترابي أو مركب لقبته وحيابه لو قبت له هلا أما طبعاً إنسكتسايد أنا قلت أما وحيا مركب لوجو هرتي كرم مجرد سوماليان مركب جونا أنا سوماليان ده وعدنا مجرد وحيا مركب فكت هدي بدلاع عذر كي أي دعوة إنه دلاعه أو متقارن مكانك لما وحيا أنا وادك سكر مجرد أو أنك هرتي فكت أنك هرتي كرن أنا متقارن دبعت وسي جيستو وعذر كان معناه سيت ترانسميت كرينا وسي كلين حالي دات وسي كلو بيجي
ومع تنتا محمد سؤال ونكسن ويان ها حقيقيا هرتا مر والبو epidemiological perspective بعذر بدنا لقى جارهان مركيهين infectious إلا لبدي يكون يعني ريفت فالي بان كهadlayna ريفت فالي markii ugu horreysay oo la helay wuxuu ahaa 1930 ilaa iyo 2000 kama una dhex bixin Afrika gaar ahaan weliba geeska Afrika geeska Afrika iyo dhinacan iyo centralkaba markii dambe kiisaska dhinaca xataa u gudbeen laakiin isku soo duuduuba Afrika kama una bixin ilaa 2000 laakiin scenario-gu wuu isbedelay markii laga helay Saudi Arabia iyo Yemen inkastoo ayaga ay ku doodayaan ay leeyihiin macnihii aanay ahayd kiisaska kuwo xoolihii cudurka qabay oo laga soo dhoofiyey geeska Afrika ay ahaayeen dadkii la contact gareeyay waxa cudurka qaaday. Dad badan baa ku dhintay, dad fara badanna hosbitaalka la dhigay. Innaga marka awooddeena maadaama iska kooban tahay, waxa kaliya la samayn karaa horta kow waxaan dhihi lahaa waddamadeennan soo koraya ee dhaqaalaha badan inaan haysanin, dhibaatada ugu weyn oo haysato waxa weeyaan datadan iyo informationka ama waxaan la yiraahdo early warning systemkan aad iyo aad uma adko. Macnaheeda waa maxay? Marka horeba Soomaalidu waxay tiraahdaa daad intuuna ku soo gaarin baa la iska muusaa. Inaad iska muustid mekanismyada aad samaynaysid waa inaad horta meel dhigtaa. Maxaa ka mid ah? Wax walba waa inaad data heshaa. Datada iyo informationka waxay kaa caawinayaan waxa soo socdo inaad predict gareyn karaysid ama aad saadaalin karaysid. Laakiin hadduu outbreak-ii dhacay, su-aashaada ahayd hadduu outbreak dhacay si uuna dad fara badan u saameynin, xoolo badan u saameynin, meesharada ka horeeya aan qaban karayn muxuu yahay? Waxaan niri vector baa keena cudurkan oo aad iyo aad u kala gudbinayo. Vectoradan meelaha ay ku bacrimayaan ama ay ukuntooda ay ku dhalayaan ama ay ayaga laftigooda ku badanayaan oo dhan in meesha laga saaro. Intaad vectorka la target garay aad bay muhiim u tahay, laakiin interventionkii East Africa markaan ka hadlayay vector controlka waa minimal, aad iyo aad buu yaryahay. Kuwa kala yara dhaama waa laga yaabaa in quarantine la sameeyo, waa laga yaabaa in slaughteringigan ama xoolahan la qalayo xilliyada ciidahoo kale in la yara joojiyo, livestock movementiga in la yareeyo. Laakiin xagga vector controlka oo pointiga ugu muhiimsanna ay ku jirto aad iyo aad baan uga hooseynaa. Marka inta taa laga gaarayo early warning systemkeena in la adkeeyo, haddii uu dhacona in la sameeyo wixii la dhihi jiray macnihii containment, yacni qayb buu ka dhacayaa, qaybta inaanan xoolihii ka bixin ee meelaha kala gaarsiinin, ayadana markaaba la bilaabo in spraying la sameeyo meelaha ay ku badan tahay kaneecadoo kale in laga buufiyo si aad iyo aad loo yareeyo populationka kaneecadaas oo kale. Taana waxay aad hoos u dhimaysaa transmissionkii, sababtoo ah kaneecadan weeyaan waxa aad iyo aad role ka ciyaarayso transmissionka xoolaha kale iyo dadka kaleba.
Thank you. Thank you, Dr. Mohammed. We can conclude the last question that Ibrahim Abdullahi put in the chat box. Please have a look.
Morning. Rift Valley outbreak occurs in southern Somalia. The disease transmitted to human through contact with infected animal, blood or tissue, particularly during the slaughter or handling of affected animals. The poster lists and the people who slaughter the animal, mostly they do not know mostly to how to control for those people living in rural areas. Well, sometimes Ibrahim is very good because, as I have said, we should have to advocate, we should have to educate, we should have to make more communication, more community awareness, risk communication, community engagement is very critical. People who are handling those tissues, blood, milk, and other, if they are not having enough knowledge how the disease can be transmitted, it will be a risk for them and also throughout the other population. So this is our assignment to increase our community awareness and the risk communication, produce many educational materials, leaflets, brochures that can be written in a local language, distribute them, discuss with them. If you suspect such kind of a disease, please take care, don't slaughter animals, don't contact with such kind of infected animals, and make precautions for having such kind of personal protective equipment and the rest. So Ibrahim, I fully agree with you because your question is the major transmission from animal to human. It's through the contact with the infected animal. It's a very rare with the mosquito or the vector. So we should have to increase that community awareness.
Thank you. Ali Musa, please make it short little question, so then we can conclude. Please go ahead.
السلام عليكم. أنا وسلامتي أخاترتا دمان أنت كنت تعرضي مع المنبع وأنا كحمة سومالي لأنكو هذا لكن وحرري سؤال رنا ويديو ومسكحدك دحوري جيسا وحوغا عدنا سيمبل أو فود مران كهذا نوع بريفنشن حوغا حاجر تقف كنعذا مرا كنعا إنو حدو يو حوغا وحياو سمين كرا موقتا إنو كنعذا سكا دفاعو لكن maxaa koos garanaya qofkani hadduu erdiisa xidho ama daaqadiisa xidho uu qolka meel ka seexdo yacni kanaacadii inay og tahay qofkaas inuu meesha jiifo waxaa koos garanaya raba inaa ogaado amasantii
Ali waa mahadsan tahay waa kolley entomologist miyihi qof entomologist waa ku fiicnaa طبعا خصبنا مع مرة والبمر كنا عين الاستعمال ورنتا هل مثل لكن إنه كو خلدامين كنا عوين كلفت وهذا فيكتور كان سبيشيس هي كل دوين باجرو قاركود آد يد هذا مالها يكون بدينيين إكرس بدينيين كو كلا مالها يكون بدينيين سيدا ملاريا ذو كلا ملاريا ذو واحد أدو يجي سيت سبيشيس كان فلسكويان كوا مالها يكون بدينيا مركا لبربر ديجا كوا كلا kuwa way ka risk badan yihiin area-ga kale. The same is true with Rift Valley fever. Marka mar walbo area-ga iyo vectorada specieska nooca ay yihiin iyo meelaha ay ku badan yihiin hadduu qofku ku nool yahay waa inuu taxadarkiisa uu ka bataa dadka kale ee meelaha kale ee lagu yaqaano. Taana waxaa lagu helayaa waa research. Su-aasha qofka hadduu qolka gees ka seexdo baasha maxaa soo aan kaftama kolley adiga haddaad ku jirto kuwa ay soo raadsanayso dhiiggaada inuu macaan yahay laga yaabaa ee aad iyo aad u jecel yihiin laakiin taa qofka taa waa iga kaftan waxaan aqoon u leeyahay maaha aad iyo aad waxay ku fiicneed qof entomologist ah laakiin si generally waxaa jiro qofka dhididkiisa iyo urkan dhididka laftigiisa waxyaalaha soo jiitay bay ka mid tahay sida dharka laftigooda دراسات فربضنا ولا سميه بيجرو كلر كاد قادني سد شارك نوع قادني سد لفتي سو ولي بقارهان دد كان هود كيوميلها جيدها يدور كوبدن كان عاده كوبدن مرك لفتيغودا كلر كودا way ka soo jiiditaan badan yihiin marka la barbar dhigo kalarada kale marka laakiin jawaab su'aashaad weydiisay jawaab uma hayo طبعا waxay u baahan tahay research haddii qof kale oo ka jawaabi karo uu jirana waan ku soo dhaweynaya taana waa iga kaftan.
Yeah, thank you, Dr. Mohammed. I just want to invite Dr. Abdullah Ibrahim, who is our parasitologist in Brown University. If you hear me, Dr. Abdullah, I would like to translate the question, then I will ask you to raise, okay, your points. The question was, how mosquito attract to people? In summary, how mosquito know that I'm sleeping in that room and how she attract me? What causes that?
Hello.
I hope you understand, Abdel. Yes, you are here. You are audible.
Ahmed, the question agrees. He is asking about how mosquito being attractive to human or something like that.
Yes. You're right. Yeah.
Okay, thank you, and thank you, Dr. Mohammed Ibrahim. I wasn't interfere because I was late, because my computer was looking for updates. So I said, let me learn from the questions first, then I can catch up with what you already presented. Thank you, and I'm very glad to see you again and to listen to you. Let me, because of the time, to go direct. Okay, the question is very interesting, by the way. Yes, parasitologically, all vectors, by the way, all insects and even ticks, there is biochemical attractive for the host, whether it is human or animal. There is there is receptors, yes. Whether this receptors is biochemical or even biological. For human issue directly to the mosquitoes, always in introduction of parasitology, we teach the students that the parasite is not here to harm anybody. The parasite is here, whether in human or any host, for a specific nutrient. Always, all the parasites, they go to their host as a specificity or predilection site in the host, whether he is going for blood or for something like that. So the specific nutrients that always mosquito needs mostly is the best one to be found in human more than even animals. If there is human available, mosquito will not go even to animals. So the nutrient biologically is one of the biological attractants to the insect, wherever it is or whatever it is. So in summary, the answer is there is biochemical and biological attractants to all vectors, and mosquito can feed on human. They mostly like blood of human. This is because of the nutrients they want. Even for the mosquito to lay egg is found in human, better to be, that protein is found in human blood better even than animal blood. So I think this is what I can say on this issue. It is not haphazard. يعني when we come to تأصيل العلوم, we said always on this in this question for the students, سبحان الذي أعطى كل شيء خلقه ثم هدى. Nothing عبثا يعني. This is the answer here. Thank you. I hope I answered part of the question, but it maybe not all. Thank you.
Thank you, Dr. Abdullah. You said in right way. I hope every one of us understand.
Additionally, for human, where he gives the issue of sleeping. By the way, the issue of sleeping in human is very good for mosquito. So biologically, feed at some of them feed at night, some of them feed at Malin or at daytime. This is also, it will be in this question, by the way. So even mosquito, when they come to feed at night, they wake up their host, not to worry him or to wake him up. No, they wake the circulatory system. That noise, that voice they did, the worrying voice mosquito female did, is not to wake up you as a host. It wants to wake up the circulatory system, the periphery circulatory system, so as to suck blood. This is just if it can add some understanding also for going to human before animal, and why human, not animal first, or something like that. In addition to the biological receptors and biochemical attractions, pheromones and ketones, all these work together for attracting all insects or arthropods as vectors to their host in general. Thank you.
Thank you again, Dr. Abdullah. I hope maybe if I can add one more point about this. Also, carbon dioxide is a part of that. As human, we release carbon dioxide and took oxygen. So when we release carbon dioxide, mosquito also attract that.
Yes, this was also biochemicals. Chemical issues are there, all of it.
Thank you. Thank you, Dr. Abdullah.
Yeah.
And now we are getting the end of our webinar. I just want to thank you, all of you, especially Dr. Mohammed Ibrahim, for a nice presentation and for your question, as well as the participants for your interaction, for your questions. I hope all questions asked. If you want to rewatch again, we will post, no worry. Just before we conclude, a short notice. Our next presentation will be anthrax, and it will be a more interesting that we will have Dr. Sofyan Moore from University of Liverpool and ILRI Ethiopia. So it will be 14 June next month at the same time like this. Thank you again. I wish you the best all, and thank you to Ibrahim again.
Thank you so much, Dr. Amir, and all of you having me, and also the very interesting interaction, questions, comments. I am looking forward to meeting you in other occasions, inshallah.
Thank you. Assalamu alaikum.
Wa alaikum assalam.